All right, I'm pretty informal. This seems really formal, but disclosure: I'm 5'6", but my driver's license says 5'7". So I'll make this short and sweet. I just kind of went through and I thought to myself, okay, I'm just gonna do a little slide presentation of what I normally see in the office every day. People coming in. Of course, we get to see all sorts of stuff, but these are just a few of the most common things. Y'all are welcome to interrupt me. You're welcome to ask me questions afterwards, whatever you have. So bunions, this is probably one of the first things that I see every Monday morning. You know, people always come in and they call a bunion a lot of different things, but a bunion is just really that knot on the side of the toe. And people always think of it as a growth of bone, and it's not really a growth of bone. It's actually technically a normal bone that just moves out of position. So if you can look, this bone right here behind your big toe is called the first metatarsal. There's really no extra bone there. It's pretty much a hereditary thing. And what happens is that first bone moves over, the big toe gets pulled over towards the second toe, and not all the time, but usually most of the time, at some point it'll actually start to hurt. It can start to hurt because, one, it starts to rub in the shoes, and then the other thing is I tell people that joint is really halfway dislocated all the time. So that's a lot of the reason that it starts to hurt. People always want to know, well, how do I know when I have to have something done with a bunion? And I tell people, you know, when it starts to bother you, you'll kind of know it's time to have something done. And over a period of time, if the bunion gets bad enough, it actually wears away the cartilage, just like if someone has a bad hip, a bad knee, bad shoulder. Same thing, it wears away the cartilage and can just start causing more and more pain. So the treatments, everybody always hates that first one. You know, one of the things you can do with the bunion is just trying to buy a little time, is to inject a little steroid in it. I usually tell people, I mean, sometimes that works wonders, sometimes it doesn't do much at all, but it's at least a conservative option, trying to get it to calm down and not hurt for a while. The other option is you can a lot of times put people in an insert in their shoe called an orthotic. Most people agree an orthotic is not going to straighten a bunion out, but because it does help control the biomechanics of the foot, you can at least slow down the progression of a bunion. And then, of course, the last option is you actually correct a bunion. A lot of times people think with a bunion surgery you actually go in and just shave off some of the bone. You really can't do that, because the whole purpose of correcting a bunion is you have to line the joint back up so that the toe is straight, it doesn't rub, but also so that that joint moves straight up and down. When people ask me, they say, well, you know, my bunion does hurt me, but how will I know when it's time to actually consider fixing it? I tell people, whenever I look at their x-rays, if the cartilage still looks good, meaning there's not a loss of it, then that means they still have a window of when to fix it. But when you start to see that joint space, which is right in this area, as it starts to get narrower and narrower, then it's more imperative that you do correct it so that it doesn't ruin the cartilage completely. Arthritic bunions. This is another one. People come in and go, well, you know, I think I have a bunion, but I don't really have a knot on the side. People can also get what's called Hallux Rigidus, and you can get this a lot of like turf toe, people jamming their toe multiple times, or it can also just be something that forms. It's not a knot of bone on the side like a bunion, but it's basically the great toe joint becomes arthritic. And then what happens is every time the toe tries to bend or someone kneels down, the bone hits the bone, and of course they have more pain, just like, again, an arthritic hip or an arthritic knee. So the options for that, I put the little emoji face here because there's not a lot of great conservative options for a Hallux Rigidus or an Arthritic Great Toe, because once that cartilage is gone, you could try to inject it, you can put people in an insert, but it's still going to grind and it's usually still going to hurt. Most of the time you have two options when the great toe has become so arthritic. One, you can replace the great toe, not the great toe, but the great toe joint. And again, just like a hip or knee, it's a small implant, usually made out of a form of titanium, just to give the toe a smooth surface to move on. And then the other option, if the implant isn't a possibility for the patient, sometimes you do have to fuse a great toe, which sounds horrible. It's really not. I tell people when a joint is arthritic, a joint wants to move all the way or it wants to move none of the way. And so when you actually clean it up and take the rest of that motion out, you usually alleviate all the pain. Posterior tibial dysfunctions, fancy way of saying acquired flat foot. You know, I have a lot of people, I see a lot of young people Parents will bring their kids in and they worry that their feet are flat. That's not necessarily a bad thing. The only thing is if they are starting to have symptoms kind of at a young age, once they start getting 12, 13, they start to get bigger, they start to get more active. A lot of times they will have pain at some point. Acquired flat foot is basically someone who's had a normal foot for a number of years, and then they start to notice that their arch starts to get sore, the foot starts to drop. There is a big tendon called the posterior tibial tendon. It's a muscle on the inside of your leg, turns into a tendon just above the ankle and attaches on your arch. And in some people, what will happen is that muscle starts, or tendon actually starts to attenuate, which is a fancy way of saying it starts to stretch out. Rarely does that tendon just tear completely in half, but I describe it to people, instead of being like a cable, it eventually kind of turns into a rope and then into a rubber band. It just stretches out more and more. And it starts to hurt because when you step, those joints in your arch basically start to kind of come out of position. So that acquired flat foot actually starts out being flexible, and then over a period of time, if it goes on long enough, the joints actually adapt to that position and it becomes rigid. So the different options, there's still a lot of conservative treatment options with this, especially when people catch it early. Meaning they'll start to go, man, I think my arch is starting to drop, I'm having some pain in that area. A lot of times you can put them in an orthotic. Every now and then you'll find somebody where you actually have to do more of a brace because it's so severe. And then in those cases where you can't get it calmed down with conservative measures, sometimes you can repair the tendon, but oftentimes what you actually have to do is fuse one or more joints in the foot, which is not fusing the ankle, so the foot still moves up and down. What you're basically doing is stabilizing the arch so that it can't drop and hurt like that anymore. And then ankle arthritis. There's two different kinds of arthritis, and it's for every joint. There's what they call primary arthritis, which is basically like osteoarthritis, meaning it's just wear and tear over a period of time, the cartilage gets worn away, and people start to have pain. And then you have secondary arthritis, which is usually arthritis that comes from some type of specific injury. A lot of times, especially like the ankle, someone breaks an ankle, even if it's fixed, it's put back together perfectly. A lot of times what happens is you still have problems with the cartilage, and I tell people it's like all of a sudden you took that joint and you aged it several years. It just basically just wears away quicker, and people will start to have pain. And again, that's an example of just a normal ankle joint on the left on the top, and then an arthritic one on the bottom, same on the left and then the right down at the bottom. So the two different options for ankle arthritis, because an ankle seems like a small joint, but anybody who's ever had ankle arthritis or even had an ankle injury, it's a painful thing, and it can be definitely comparable to a bad hip or a bad knee. If things like the injections and the bracing don't work for the ankle arthritis, one of the options is you fuse it, which again, it definitely changes the way people walk, but in most cases, because the pain was so bad before the surgery, you really can't help but make it better by stopping that motion. And then also, people are always surprised to learn that you can actually replace the ankle joint. You can replace the ankle joint. I still have some patients come in and go, well, I've heard the ankle replacements, they don't really last, they're not very good. Well, when they first started doing ankle replacements years and years ago, especially back in the 70s, what they essentially did is they took a knee joint, made it smaller, and flipped it up down. Well, a knee and an ankle don't have the same kind of biomechanics, so the implants had a really high rate of failure. So they kind of fell out of favor for a number of years, and then really in the mid and late 90s, there was a big interest in ankle replacements. They started doing a lot more research, and so a lot of the implants that they have now are extremely good. They last for a very long period of time. And again, people always wonder, well, what's the difference between the two? What are the advantages, disadvantages? Well, both of them have the same goal of alleviating pain. In most cases, I love to do an ankle replacement if we can instead of a fusion, just because most people do better at least having some motion as opposed to no motion at all. But again, both of them are good options if you have to have the surgery. And I think that's all I have, PowerPoint-wise. Anybody have any questions? Yes, ma'am. Go ahead. Okay. Okay. It can't. Well, did they say what bone it was? In your ankle? In that? in the ankle and foot. There's a few different things that can happen. I've had some people, like if they have an injury, it can happen. Even if it's a little crack in the bone, what can happen is you lose your blood supply to part or all of the bone. Sometimes it can come from like long-term steroid use. It's not as common in the ankle as it is in like the hip, but it can happen too. Sometimes people, if they have a history of any kind of sickle cell problem, that can actually cause problems to the blood supply of the bone. What have they been doing for it so far? In the boot. And the biggest thing is whenever you have any kind of what you call avascular necrosis, where a bone starts to lose its blood supply, what you typically do is you want to immobilize it, because the less it moves, the better chance it actually has to try to heal itself. And also the other thing is the more you immobilize it, the less the chance of the bone deforming, like kind of crumbling down. And a lot of times what I'll do too is put people in what's called a bone stimulator. Bone stimulators have been around for years. What it is typically they either send an ultrasound or a little electrical current through the bone. What it is meant to do is to stimulate the bone to try to get it to heal itself. You can't really reverse any damage to the bone that has already occurred, but a lot of times what you can do is at least try to get the bone to heal itself so it doesn't deform anymore. Yep. Yes, back there. Oh. Okay. Yes.
So how long is the recovery after these surgeries?
With like an ankle replacement, the big thing is with the ankle replacement is an ankle, they're all what you call press fit. What that means is all the cuts have to be just right, and you actually impact the implant. You actually hammer it into position. And so what happens is you have to keep people non-weight bearing for around 6 weeks. 6 weeks because you have to wait on the bone to actually grow into the implant and hold the implant. I tell people if you like pick up one of the ankle replacement implants, there's 3 different parts. The part in the middle you can't see because it's plastic. But the metal parts, if you feel the back of them, it feels like sandpaper. If you look at it through a microscope, it looks like a bunch of coral because, again, you want the bone to grow into that implant. So most of the time people don't do any weight bearing with the ankle replacements for about 6 weeks, and then usually you kind of keep them in a walking boot for about 3 to 4 weeks, letting them do range of motion. After that, we usually put them in physical therapy. With a bunion, with most bunions, you can let people walk on it right away. I tell people it doesn't mean you walk fast, but there's not a non-weight bearing period. Same way with the replacements for the great toe. If you're talking more about an ankle fusion or a fusion of one of the other joints for like the flat foot problem, a lot of times you actually have to keep people probably non-weight bearing for about 8 to 10 weeks, and then in a walking boot for a period of 3 to 4 after that.
So would they be working after?
I tell people that, especially after a procedure where they can technically bear weight on it, I tell them they can do what they feel comfortable doing. I do my surgery on Friday, and I know a lot of people go, well, I think I'm going to be able to go back Monday since I can walk on it. And I go, in theory, you may be able to, but, normally it's nice to at least have a week, few days, even after a bunion, to just be off of it, to be able to kind of prop it up and take it easy. After that first visit, which is about 4 to 5 days after surgery, people usually feel like they can start doing a little bit more. But I tell people, even with a bunion, it takes most people about 6 weeks or so to feel like, hey, I'm getting around pretty good. I can see there's light at the end of the tunnel. So, yep. Yes, ma'am?
What causes heel spurs, and what can you do?
Well, heel spurs, whether you have, there's 2 different kinds. There's one on the back of the heel, back, and then there's one on the bottom. On the back of the heel, that is actually, there are 2 muscles that come out of the back of your leg. There's the gastrocnemius muscle and the soleus muscle, and they blend together to make the Achilles tendon. And in most of us, we don't do much stretching or anything like that. Those 2 muscles are really powerful. What it is it's actually a traction spur. What that means is it attaches along a shelf on the back of your heel, and over a period of time it pulls. And I tell people when it pulls and it bleeds and it pulls and it bleeds and it calcifies. So if you'll x-ray, I tell people if you x-rayed everybody in Arkansas, half of them would have a spur back there. But what tends to happen is that when people start having pain back there, it's usually from one of 3 things. You can get a little bursitis back there where your body actually tries to make a little sac to cushion it. And then the other thing is because it does pull all the time, people get like a little chronic tears at the attachment, and that can make it start to hurt. And then one of the most common things is like when they've had a knot back there and it hasn't bothered them, and then all of a sudden one day it did start hurting. I usually see people, and it's like they were, up and down a step ladder, for 3 or 4 hours on the weekend, and what it does is it actually cracks that spur, and that's why it starts to get painful. Most of the time with any kind of treatment, what you want to do is you immobilize people at first. Means I usually put them in a walking boot, and I'll usually put them in a little bit of a heel lift. That's to raise the heel up to take tension off of that so we can try to let it mend itself. I tell people it's not like I put them in the boot and see them back in 2 months. Usually I'll put them in the boot and see them back in about 3 to 4 weeks. If in about 3 to 4 weeks people feel like, hey, we're headed in the right direction, it's usually about another 3 to 4 weeks in the boot. If they come back at 3 to 4 weeks and they're still like, well, I still feel this, then most of the time I'll go ahead and do an MRI to see, okay, is that spur really cracked? Do we have, quite a few chronic tears back there? Physical therapy, a lot of times you do physical therapy. You don't usually inject very often around the Achilles tendon if you can help it. Because that can, weaken it for a couple weeks. And then the very last, cases, if it's just not getting any better at all, you basically have to take that spur off. But I tell people that it doesn't seem like a big surgery, but it's a bigger surgery because that spur is in the tendon. So you actually have to detach part of the tendon, clean all that spurring up, clean the tendon up, and then reattach it back to the bone and let it heal back like it's supposed to. Okay. Yes. Fasciitis. That's plantar fasciitis. People always want to know what's the difference between like a heel spur on the bottom and plantar fasciitis. They kind of go together. I tell people if you x-rayed everybody in Arkansas, half of them would have a spur on the bottom of their heel and wouldn't have any pain. There's a ligament that goes from the bottom of your heel to the ball of your foot called the plantar fascia, and it basically pulls. And it's not so much that spur that hurts, but what it is it's that constant pulling and tightness. People always worry if I take an x-ray and they have a spur on the bottom of the heel that they're going to have surgery. I tell people if I see 100 people that have a heel spur on the bottom and they're having pain, I might have to operate on 2 of them. Most of the time the big thing with plantar fasciitis is stretching. A lot of times we'll put people in a night splint, which is something that they wear at night that just basically tries to stretch that out so you don't have that constant pulling. A lot of times you will inject it. I've had plantar fasciitis before. I injected myself twice. That was years ago. It's not as bad as people think. And then a lot of times physical therapy, sometimes inserts. One thing that I've had some really good success with the plantar fasciitis is a PRP injection, which is, I tell people all the professional athletes get stuff about 3 years before everybody else. So they basically draw off some of your blood, spin it down, and the little layers of growth factors in the middle, you take that off and you inject it into the plantar fascia. You're basically trying to get it to heal itself. Every now and then you'll find somebody where it was sore for a while and it did go away. I tell people, they always wonder how long should I wait before I know, okay, this is officially stubborn. If people have plantar fasciitis, usually 3 to 4 months. If in 3 to 4 months they're still like, boy, I'm still limping around, you start getting past that point, the chance of it just up and leaving just get less and less. But usually, even at 3 to 4 months, if they're like, okay, it's not perfect, but I can definitely tell it's headed in the right direction, usually it's going to be okay. Yeah, it's pretty not, it's probably not just going to go away. Yeah, you have to learn to walk on your hands. So, yes, sir.
Metatarsal connects the ball of the foot to center arch, correct?
Right, correct. Yes, sir.
In the event of, say, the metatarsal on your middle toe,
Mm-hmm.
you break that.
Right.
Of course, if you walk on it for a period of time, you're going to wind up with a callus on one side or the other.
Yes, sir.
Also,
Right.
is a surgical procedure for that? Does it start above the ankle?
Not usually, but here's what I tell people. The metatarsals, start behind your big toe and go all the way over to your little toe. They basically, all 5 of them bear pretty much equal weight across the ball of your foot. And like I said, when you break one and it heals back, if it heals back a little down or a little up, that means that one of them or 2 of them are going to take more pressure than they're supposed to, and you'll start to develop a callus. The thing that exaggerates that is your Achilles tendon. Your Achilles tendon at your ankle, when it's tight and it pulls up, it just wants to put more and more pressure on the ball of your foot. So sometimes what you do is, because when you make a cut in one of the metatarsal bones, you try to line it up as best you can so it's perfectly level with the rest of them. But again, that can be it can be a little bit inaccurate. So sometimes what you'll do, especially if people have one or two areas that are bearing a lot of pressure, if you examine them and you find out their Achilles tendon is extremely tight, so it exaggerates that. And if you can't get that stretched out, you will sometimes actually do a little lengthening in the back of the Achilles tendon to lessen that pressure on the ball of your foot so that it doesn't just overload it.
Is there typically a time limit or something somewhere in the event that happens where you broke the metatarsal, where you deal with it for years, you have callus for years, you fight and everything?
Right.
Is there a point where surgery is pretty well not viable factor anymore?
Well, the tough thing is like if you break one and it raises up, and the metatarsal next to it is taking pressure. The tough thing is if that one has been out of position so long, it's going to be really hard even to break it and reposition and get it to bear equal pressure. So sometimes what you would have to do is the next one to it, you actually cut it and let it raise up to match it a little bit. The tough thing is when you do that is then it can go down the line. Exactly, move it over. So a lot of times, especially if you have like a lesion on the bottom where it's taking all the pressure, you know, the number one treatment I usually do for that works really well is to just put people in an insert, and you can just have it made where it just offloads that area.
Yeah, what they don't pay is after you get on Medicare.
They don't cover. Yeah, yeah. That's the tough thing with it. Yeah.
I had a person tell me that after you get on Medicare, they really don't care if you walk or not.
Yeah. Anything.
I still enjoy walking.
Yeah, that's right. Still got stuff to do. Any other questions?
I have one more.
One more. Yes.
As far as the PRP injection goes, what would it be good for? Like injuries or
I have used it. I've used it for like ankle arthritis. I've even used it for like arthritis of the great toe. It seems to work well for that. I mean, to me, at least in the people I've used it on, I think it works better for like soft tissue injuries that just won't heal. Like I said, I've had good results with plantar fasciitis, but also if sometimes people get like a chronic tear in their Achilles, where it's not back there where the spur it might be, but just above it a couple inches. That's what's called the watershed region of the tendon. It doesn't have a good blood supply, and you'll inject that. It's basically trying to get that area to heal itself. So, yes.
You mentioned the PRP. Is this in conjunction with stem cells? Are you doing stem cells and PRP, or is this just?
You can. They're really kind of two separate things. So most of the time, you're kind of doing one or the other. Yeah. Yeah.
One other question.
Yeah. Go ahead.
Not related to that. When you were talking about the ankle orthosis and how they're better now, what
Right.
is the expected lifespan of one now? Within general, specific cases.
Yeah, most of all the implants that are out now, which the ones that they have in Europe are, they because of the FDA and everything, they just have some that they have more choices than we have. We have about 4 choices here, but pretty much most all the research shows they last about 18 to 21 years. So, yeah, and a lot of that just depends on the size of the patient, activity level of the patient. Yeah, sure. Right. A pill? Yeah, I mean the biggest thing is anything that reduces inflammation, because that's still, even with that spur back in the back, usually what hurts is really just is that constant pulling, so it stays constantly inflamed. I tell people, even with the spur back there, it's like you had a cut on your arm, and every 12 hours somebody comes and pulls it apart. It's going to stay sore and not heal. That's exactly what that Achilles tendon is doing back there. So anything that you can take that's going to reduce the inflammation is at least going to help with the pain. Aleve, Advil, even prescription anti-inflammatories, but even like I take that turmeric. I think it works. Turmeric. It's just it's just a natural anti-inflammatory. So, yeah. Okay, are we done, Tina? All right.
Any last questions for Dr. Burks?
Yes, ma'am. Yeah, if you truly have that where the blood supply to the bone is compromised, the big thing is just as much protection as possible. And like I said, no, really no exercise that's going to help it. It's basically trying to mobilize it and honestly be off of it as much as you can so your body actually has a chance to try to heal it, try to get blood supply back in there. Yes, ma'am. Mm-hmm. Yeah. Well, I think, the big thing is how long has it been going on for? Last 2 weeks in April. A month. Yeah. The boot is definitely the best thing. Like I said, the bone stimulator is something to consider too because those have been used for a while. And that's something it just goes on the outside of the foot and you use it a certain period every day. Different ones are different lengths of time. Most of them you use for about 20 minutes a day. Some use for 30 minutes a day. Some of the older ones you used to have to use for hours. But again, it doesn't hurt. You don't feel it, but it sends that either ultrasound or a current through it, and it's just meant to try to get that bone to heal as fast as it can. Yeah, usually go to the doctor and they'll get in touch with one of the companies that has bone stimulators and they'll do a prescription for it, and the rep kind of comes in and shows you how to use it. They're real easy to use. Yeah. And like I said, the good thing about that is it can only help. It's not gonna harm anything.